I resume?
I am.
Okay, fantastic. So this might seem obvious to you guys, but just like in the regular CCSE, there will be no intimate exams in the online CCSE for all the obvious reasons that have always been there, in addition to the fact that we're not physically in the same place. As always, if you feel one of those exams is indicated when you're talking to the SP about what you'd like to do next, you say, you know, I think it's going to be necessary to do a pelvic exam. I think we're going to need to check a rectal exam. The SP will direct you to, they'll say, that's fine, you should document that in your note. And what you'll do is you'll just put that into your note in the diagnostic test section. So you're going to be asked in your note, what are the future additional tests that you would like to do to find out what's wrong with this patient? And those exam maneuvers that you're not able to perform in this setting will just be listed as part of your future plan. Does that make sense to everybody? So you would just list it as a diagnostic test, just like you would list pelvic ultrasound or abdominal CT or CBC. You would list pelvic exam, rectal exam, breast exam, etc. Okay. So any questions about physical exam and how we're going to handle physical exam before we move on? And again, just shout them out for me. All right. So interpersonal and communication skills are going to be very similar to how they normally are. We are using the same exact assessment tool that we use in the normal CCSE. We're going to be having the standardized patients rate in the same fashion that they do in the CCSE. The one thing, and I'm actually really interested to see how this is going to come out, when we look at the scores, because as I'm sure you guys know, it's a lot more difficult to connect interpersonally with somebody online than it is in person. Like right now, I'm looking at a lot of you just showing up as static pictures of yourselves or as black boxes with your name. I'm talking to somebody whose name is 12345 right now. Clearly, it is harder for me to connect with you and to gauge your receptiveness to me in this environment than it is in real life. So some things you can do to kind of help mitigate that, you know, just keep an eye on the facial expression of the standardized patient. Pay attention if there's a change in voice tone or a change in cadence. They could be signaling to you that they're feeling some kind of way and you should address that. You can also check in with them maybe a little bit more frequently than you would in real life. How is this sounding to you? How are you feeling about all this? Tell me what your thoughts are. You know, the more you give them kind of opportunities and open the door for them to share their emotions, the better you're going to be able to understand where they're coming from and connect effectively with them. And make sure that you're giving them opportunities to ask questions and to assess their understanding, as I'm trying to make sure that I do with you guys periodically right now. The actual assessment tool that we use for communication skills is not a trade secret. There are 7 items on it, the first 5 of which are scored, actually the first 6 of which are scored via 5-point Likert scale. So that is eliciting the story. How effectively do you get the patient to tell their story, and how well do you bring out all the important details of their story? How clear are you in explaining things back to the patient? So when you explain your thought process and what the next steps are going to be, how clearly do you do that? How effectively do you close the interview? So, you know, have you given them an opportunity to express their own concerns and ask questions? Have you made it clear to them what's going to happen next? How effectively are you supporting the patient's emotions? So that's where recognizing their emotions, which is so much harder to do online, becomes really important, because a lot of these cases do have some kind of emotional undercurrent that we hope that you will recognize and address. So the SPs are going to be looking for that. And they're just going to be looking for your ability to relate to them as people and to build a personal relationship, even though you're in the online setting rather than in person. The sort of global summary question that we use is, how likely would you be to return to this student as your doctor? So that's kind of their overall sense of like, yeah, I like this person. They seemed concerned about me. They seemed to know what they were doing. Their explanations were clear. They cared about me. I would be likely returned to this person, or gosh, no, I wouldn't. And that really links into whether the SP has any concerns. So they have a separate question that doesn't actually get factored into the score for communications, but it's a place where they can denote if they have significant concerns and describe what those concerns are. And it's a really rich source of feedback for our students from the SPs. So that's basically our communication assessment process. Any questions about that? Oops, okay. Anything? All right. So what is the exam day going to look like? You guys are hopefully all signed up for an exam day at this point. It is a full 8 to 5 day. And I would just like to say for the record, and hopefully some of you guys are like MSS reps and you can corroborate this, but back in the summer when we were talking about what to do with CCSE in this crazy COVID year, one of the ideas that we had was to actually do a shorter CCSE so students would get the experience and the opportunity to practice with this type of exam, but it wouldn't be like an all-day Zoomathon. And several students actually felt pretty strongly that having the range of cases and the that full day examination experience was valuable in terms of preparation for Step 2 CS. Now, this conversation took place before Step 2 CS went away, which was, or at least was placed on hold, which was a more recent development. But a lot of the students really advocated for the variety and experience that you get from a full day exam. So that's why we kept it as a full day exam. So that's one where you can have a conversation with your classmates if you're concerned, and don't completely take your feelings out on me if you would have liked it to be shorter. Okay, so you're gonna be there all day. You're gonna log on to Zoom by 8 a.m. You're gonna start off in the waiting room, and then you'll be admitted into the main exam room at 8. There'll be a brief orientation and you'll have the opportunity to ask questions about the exam. Your first encounter is gonna start at 8:30. And then you're going to have 12 cases over the course of the day. So you get lunch after the 6th case. There's short breaks after the 3rd and 9th cases. And there's actually short, like 5-minute breaks in between each of the cases. So the case is 15 minutes. The post-encounter note writing is 10 minutes. And then there's another 5 minutes before the next case starts, which gives everybody a chance to stand up, stretch, run to the restroom if you need to. So you're not going to be completely glued to the computer the entire day. But no question, you're going to, potentially be there till 5, and it's going to be a long day. Now, we've always been very strict on our timing for the CCSE, but I have to tell you this year it's going to be even more rigid, because one of the things that the SimIQ platform requires us to do is preset the exam time. So it used to be in the Sim Center, we could just sort of start and stop the clock whenever we were all ready and in place and able to do so. But now we have to pre-record or pre-program the start times for each encounter into the system. So we don't have a lot of latitude to help you out if something happens and you show up late for the encounter. We're going to be like, sorry, this is how it's programmed. We have no ability, without screwing up all the recordings and all of the checklists, we have no ability to give you extra time to make up for the time that you missed. So if you show up late for something, you're going to just lose that time, and that will probably affect your score on the encounter. So please be aware of that, and please do everything in your power to be punctual and timely in showing up for the exam in the morning and in returning from breaks. Now, that said, obviously we recognize that, we're all humans and bad stuff happens, and sometimes we can't control certain things in our environment, in particular children and pets, but there's all kinds of other variables in real life that we can't necessarily control. So if something crazy happens, if you have to rush off and attend to an emergency in the middle of the exam, if your internet zaps out, if something happens, we're going to do our best to get you back on track. We're going to do our best to help you. So please understand, we're not trying to be like adversarial about timing. We don't want to be excessively draconian about that. We just ask that you make your best faith effort to help us keep on time. But if something really unpredictable happens to you, you get thrown out of the Zoom meeting, a tree falls on your house, your internet goes out, your computer dies, we're gonna work with you. So don't worry too much about those things. And that's actually a variable in administering the exam in this way. So we're going to be collecting data about that to get a sense of how disruptive those kinds of things are to the exam, because that's part of the feasibility of doing this type of exam in the future. Any questions so far? All right. So what's an encounter going to look like? So when you log into the EMS system, you're going to have a to-do list. And this is just a screenshot from my own EMS training a few days ago. So I had a couple of things to do. I had just come out of an encounter at this point. So I had a post-encounter note to complete for my last encounter. And then I had another encounter scheduled, as well as a post-encounter note scheduled for that encounter. So it's going to give you, when you come in, it's going to be a big list of things, all of your encounters for the day, all of your post-encounter work that you have to do. The live links that get you into each of those things are over here. So right now, my next thing that's due is this post-encounter work. So if I click over here on this link, that would take me to my post-encounter and I could complete it. Obviously, you're going to be doing an encounter before you do a post encounter. So if I had gone here and clicked start for my upcoming encounter, I would be told, if I clicked start before the encounter was scheduled to begin, I would be told that I have a certain amount of time until the encounter is going to be available to me. So I'm going to have this countdown clock here that will tell me how long I have until I can enter the room. Once it's time for me to start the encounter, there's going to be a start button that will become available to me. I did find in my own training that a couple of times that didn't happen and I had to refresh the browser to get that to show up. So if you find that you're waiting in your room and it should have been time for you to go in, just hit refresh, and it might just be that your browser didn't pick up on the fact that it was now acceptable for you to go into your room. So once it's time to begin the encounter, you'll get this start button and you will click start video conference, which is going to take you into good old familiar Zoom. And we all know what Zoom looks like. So there's going to be 3 participants in your Zoom room. There's going to be you, your patient, and there's going to be somebody who's playing the role of a monitor who is also a standardized patient, but they're not going to be evaluating you in this case. They're going to be monitoring the encounter. And their job is really to run the encounter to keep things on track. So they're the ones who are going to be keeping time. They're going to give you your 5-minute warning. They're going to provide any information that's necessary during the encounter that the SP isn't able to provide, like if there's any visual information or anything we want you to have. So they're going to be like the extra person who does all the logistical stuff so that you can focus on being the doctor and the patient can focus on being the patient. So once you go into the room, everybody will say hello. Pretty shortly thereafter, the monitoring SP will display the doorway information. So this is an example of doorway information that I'm just going to click past quickly because I realized that's an actual encounter that I meant to redact and didn't. So you got a little tiny 2-second prequel of one of the chief complaints. I don't really care that much. It's okay. But your doorway information is going to say where you are, what the patient's name is, their age, what they're there for, and it's going to provide some additional information, usually vital signs. And I will mention vital signs are vital. So you want to make sure you take time to read the doorway information carefully. And if at any point during the encounter, if you're like, oh crap, I didn't write down the blood pressure, you can always ask to have it displayed again, and we'll be happy to display it again for you. So there's not like a time limit on that. However, there is a time limit for the overall encounter. So you have 15 minutes for the encounter, including any time you spend reviewing the doorway information. So don't, stare at it for too long. Get the information you need and move on. Once you're done looking at the doorway information, you can say, okay, I'm ready. And the monitor will take that away and instruct you to begin your encounter with the patient, during which time you're going to obtain a focused history based on their chief complaint. You're going to ask for the relevant physical exam information that you would want for that patient. You have 15 minutes to do that, and you get a 5-minute warning when you have 5 minutes left in the encounter. That's a great time to sort of transition away from data gathering and into your part of explaining and preparing the patient for what's going to come next. So you're going to be, hopefully while you're doing your H&P, you'll be formulating a differential diagnosis and thinking about what the next appropriate diagnostic and management steps would be. And you're going to discuss those next steps with the patient and assess their understanding. At the end of that 15 minutes, your encounter is going to be over and you're going to go back to SimIQ. Any questions about what that encounter piece is going to look like? All right, and now everybody learned that you're going to see a patient with back pain. Okay. All right, so at the end of the encounter, you're going to go out of Zoom and back into SimIQ, and you're now going to have a finish video conference button. So that's going to tell the system, okay, I'm done with the encounter, and now I'm going to move on to my post-encounter note. So there's a format, a template that will come up for your post-encounter note. I tried to get a screenshot of that, and I'm sorry I didn't succeed in doing that. But basically, it's going to include, separate fields for all the things that you think would go in there. There's a history field, a physical exam field. There's 3 spaces for you to list differential diagnoses. So there's always going to be 3 diagnoses that you can list in your differential. You're not required to use all 3 spaces, but you can list up to 3 differentials. And then for each differential, you're required to list supporting data from your history and physical. So what was it about the history and physical that made you think of this particular diagnosis? At the end, there's a field for diagnostic workup, and that's actually where the USMLE note ends. But here at Hopkins, we think you guys are smart enough to also be thinking about what the management plan for the patient should be. So not just what tests am I going to get, but what treatments am I going to provide at this juncture to either alleviate the patient's symptoms or to address the underlying problem if it's clear what it is. Any questions about the note component? Shout them out. Okay, fantastic. Now, most of these notes follow the format that I laid out here, which is the USMLE format. This is exactly what the USMLE does, with the exception of the fact that we add in the management element. However, we have a couple of funky cases that do not focus on differential diagnosis in our exam. So, for example, if a patient were coming in for follow-up of a known diagnosis and they're like, hey, I'm here because I have ulcerative colitis and I'm here for my 3-month visit to evaluate what's going on with my ulcerative colitis. We're not going to be like, I wonder if this patient has ulcerative colitis or what else might be in the differential. We're going to be focusing on how well is this person's disease controlled? Are they on optimal therapy for their disease? Have we considered all of the preventive health needs that they have in light of their disease? We're going to be thinking about the big picture of this person living with this known disease. So we're going to think of that a little bit differently, typically in the form of a problem list rather than in the form of a differential diagnosis. The cases where this is relevant are going to be very obvious to you because the patient's going to come in and be like, hey, I'm here for follow-up of blah, blah, blah. And there's going to be a different type of note template that you're going to use. So just be aware that not every case is going to follow the standard USMLE format. Any questions about that?
Can we be, sorry,
Yeah.
could we be like typing into one of these notes while the patient is like,
that is a great question. You
no?
Unfortunately cannot because it's in a completely different window and it won't even come up until you've ended the video encounter. So you can't be typing into one of these notes. However, you are absolutely free to take notes yourself, with paper and pen, or if you're a good multitasker, you can take notes in like a Word document or something on your computer. Although I'd urge you to be very careful about that because you know, anything where you're like multitasking different screens on your computer is going to inevitably take some attention away from the patient. So I would encourage you to do written notes that are handwritten and don't require you to navigate away from Zoom, and that are, you know, relatively minimalistic, just things to jog your memory, not extensive notes about everything the patient says to you. Does that make sense?
Yes, thank you.
Yeah. Now, I know in real life, we do sometimes type our note at the same time as we're talking to the patient, and this exam software does not permit that. That's a great question. Other questions? Wonderful. Okay, so then once you're done your post encounter note, you hit submit. And ostensibly, that should make your post encounter note go away and it's no longer on your to-do list. I will tell you one experience that I had in my own training, and Carol corroborated that she experienced this as well, is that there are separate text fields for each section of the note. So there's like a history field, a physical exam field, a field for differential diagnosis 1, a field for differential diagnosis 2. If any of those fields are blank, the system is going to view the note as incomplete, even if the note really is complete. Like, for example, there might be a case where there's only 2 things in your differential. However, there's a third blank differential diagnosis field that's still open. The computer doesn't understand that it is not clinically relevant to fill in that field. So it's going to say this note is complete, and that this note is incomplete. And that incomplete note is going to be stuck on your to-do list. Now, you have one of 2 options. If they won't bother you, you can simply ignore the incomplete notes and leave them there, because you are able to hit submit on your notes, and they do get submitted. They just remain this annoying unchecked item in your to-do list. Or you can just go into the relevant field that's left blank and just put a period or hit the space bar or type a couple characters of nonsense or something, which will fill the field and thus making the computer think it's complete and letting you remove it from your to-do list. Either option is fine. It won't affect your exam grade one way or the other, which way you do it. Just some people will be confused and irritated by their completed notes not showing up as completed. That certainly confused and irritated me when I was taking the exam. So I wanted to just make you aware of this peculiarity of the system. Any questions about that? Did that make sense? Wonderful. Okay. So as far as scoring the exam goes, when we calculate scores for the exam, they're done by domain. So we're averaging your scores within the domain across all the cases. So we're looking overall at your ability to complete an H&P, overall at your communication skills, overall at your documentation, rather than focusing on individual cases. Because we recognize you might have stronger content knowledge in one clinical area than another, and looking at an individual case is less helpful than it is to see what are your overarching skills across the domains. So when we score H&P, it's based on a checklist. The SPs are looking for you to ask, key questions that are really important for that case, and they're going to check off whether you did or did not do those things, either ask the history question or request the physical exam maneuver. They're going to be scoring your communication on a 5-point Likert scale like we talked about. And then for the notes, the clerkship directors actually score those using structured rubrics that are based on a 10-point scale. And they're looking at all aspects of that note, the completeness of your history, the completeness of your exam, the correctness of your differential diagnosis and how well supported your differential diagnosis is, as well as the appropriateness of your diagnostic and treatment plan. Cool? Now, what are our pass-fail cut scores for this exam? Well, as you may have heard, we don't have any. So this year the exam is entirely formative. It is not, there are no cut scores where one person passes and one person fails. There's no such thing as failing the CCSE for this year. This is going to be an entirely formative experience for you. So hopefully that'll take a considerable bit of pressure off of you for this exam. So why are we still doing this? Well, first of all, I will emphasize that we had made the decision and voted on it in the curricular leadership group before the USMLE made the decision to put Step 2 CS on hold. And we have no guarantee. I mean, the USMLE could announce tomorrow that they're going to bring Step 2 back in November. I don't think they're likely to do that, but we have no way of knowing what their plans are going to be. So we don't want to leave students in a position where they're getting no preparation whatsoever for this exam, and although they could be required to take it in the future. So we've even knowing, like, this came out pretty soon, this decision came out pretty soon after we had decided to proceed with CCSE, and I was like, what do we do? And we all just decided that there's so much uncertainty, it makes more sense to have you guys prepared than not. In addition, student leadership did feel that CCSE was a valuable experience. We included student representatives in our task force where we planned for the CCSE for this year, and got a pretty unanimous sense that even though it's a difficult exam and a full day of Zoom is pretty painful, that it was still a valuable learning experience that they wanted to maintain in the curriculum. And it's still really helpful for us to see how well we're doing teaching you the things that we think that we're doing. Lastly, you know, this is going to be at least part of the future of clinical skills assessment. So we also thought it was a really good idea to take this opportunity to do an online assessment and to learn from the experience so that we can continue to use this assessment format in the future in as much as it's appropriate and relevant to do so, and do a better job of it moving forward with your future classmates. So there were lots of reasons why we decided to still do it. And we're still going to be giving you score reports, which are designed to provide you with formative feedback about how you did. This is still going to allow us to identify students who are struggling a little bit in the clinical domain. And we're still going to identify students with low scores, those who would have failed if we were using pass-fail cutoffs. We're still going to offer the same support services that we've offered in the past. So we're going to encourage you to review videos with your CAP advisor to get feedback. We're going to give you written feedback on your notes. And you are required to complete the exam, even though there's not a pass-fail component to it anymore. So the exam was agreed upon by the EPCC to still be a mandatory part of the curriculum, just without a pass-fail cutoff. Any questions about that? Okay, so score reports, the Office of Assessment and Evaluation is going to be doing those for us. They're going to generate preliminary reports in 2 waves. So they'll take the first half of the students and then the second half of the students. So depending on when you take your exam, you might get your report very quickly, or it might be a few weeks, just depending on where you are in that wave. But they're going to be doing the first half and the second half, and they're going to be providing the domains that we have immediate data about, so history and physical and communication skills, so that you get that feedback quickly. The note scoring takes a bit longer because we have to get the clerkship directors to do that post hoc, and then we add that into the final score report. So that's going to come out about a month after the last exam day. So that's going to be a good bit later than the preliminary report. We are going to provide you guys with information about normative comparisons, so you're going to see how you did relative to your classmates, as well as how you did relative to the historical pass-fail cutoffs, just so that you have a sense of like, yeah, I nailed this, or ooh, I need to work on this part of my performance a little bit more. We are not going to require any remediation exam. However, we are more than happy to help you with resources to improve your own performance if you're concerned about how you did, because we want this to be as valuable a formative experience as possible. Any questions? All right, just a couple little housekeeping things. I've alluded to this, but I want to say it loud and clear. We are going to be recording all the encounters. Those are stored behind the Hopkins firewall. They're not going to be made available for any purposes other than quality assurance for the exam, and they'll be made available to your college's advisors for remediation purposes if needed, but they're not going to be used for any other purposes, so those recordings will be confidential. We do, even though this is a formative exam, we will honor disability accommodations. Those, you know, this is a logistically complex exam, so those would have been needed to be requested well in advance. If that applies to anybody here, please reach out to me immediately. But there have been, prior announcements about that. So I think I know about everybody, or I hope I know about everybody to whom that is applicable. Again, even though it's an online formative exam, we are still enforcing the honor code. So you're going to be expected to sign the honor code at the beginning of the exam, and you're not going to be allowed to use any outside exam study materials. So we're going to ask for your, you to refrain from doing that. And then lastly, if anybody needs a schedule switch, those are all going to go through the registrar. So if you have like an emergency, or something like you get unexpectedly sick or you have a death in the family or something, let me know about that. But for like regular schedule requests, generally the expectation is going to be that you will work out a mutual swap with a classmate if you need to change your exam day. And that is all I've got for this part. Any questions right now, friends? Okay, Carol, what would you like to add in terms of technical and logistical aspects of the exam that I might not have made sufficiently clear?
Thank you. Thank you. Welcome all. Nice to see all your names and some faces. I will be the manager of the exam each day, and I do have a couple of things to add. One thing that we found is that the patients need a little bit of time to set up at the beginning of each encounter, and it'll just make things much more smooth if you join the encounter 1 minute after your appointed time. So that makes a little bit, you see that start button and just hang on for another minute and then join. And also what I'd like to do is have a debrief at the end of the morning and in the afternoon, particularly for the first group. Because we're doing this for the first time, I want to get your feedback of things that went well, things that you would suggest that we do better, and we might even be able to make changes for the afternoon. So that'll be helpful. That is optional, but that'll be set up in a Zoom meeting for you. I also have 2 documents that I would like to share with you because I plan on sending them to you. And this way you will have seen them ahead of time. And I'm doing my wonderful screen sharing, which I get to practice every day. And I will make this larger.
And you guys have seen some previews of this because some of my screenshots were stolen from this document.
And we're not going to go through it step by step, but what I'm going to point out at the very top in yellow is by 5 business days prior to your exam date, please do the first set of steps. And I recognize that at this point, we're probably at 5 business days before the first group. But what that is to allow you to try it out. If you have problems, then we have a support team to support you. And doing it ahead of time will allow us to figure things out. So this I will send to you, and then and we have a tech support team set up for the students, and there's an email address here for that. So I'm not going to go through any more than this, and just let you know that that will be coming to you. The other thing that I want to show you, so that is a general guide for learners of how to go through, and as Jules mentioned, that was a lot of what was in her presentation, so then you'll have it in another view. And then the other thing that I will be sending to you, and let me make it a little bit larger, are more details of what is going to go on that day. Even starting with that we're going to start in a Zoom and then switch over to the Simulation IQ. I have links, I have timings of different things happening, and this is something that you can refer to step through. At this time, this is what I need to do. This time, this is what I'm going to do, and step by step. I think after you do it once, you're going to go like, hey, I'm all set. But for the very first time going through it, it'll be very helpful for you to have those in front of you. And also something that'll be critical to you is that contact support. So I put that here again so that you have that. I plan on staying on the Zoom meeting and so that you come back in. So what we want to do is if you have problems, you can quickly reach out and get help. because as Jules mentioned, the timing is very critical. The timing is set for the entire day. And that's it. So delaying by 5 minutes, 10 minutes can be a challenge. And I just said the timing is set for the entire day. I'm setting it up so that I can make changes for the afternoon. And that's where feedback from you, if you say, hey, everything went well, I'll keep it as is. If you say, well, I got into the room and there was a bit of a challenge, technical challenge, and we didn't need an extra 2 minutes, I can set that up, because I would much rather have it go smoothly than having people struggle along the way. There's something that Jules did not mention is that there is a 10-minute limit for that post encounter, and
Yes.
you will see that information there. And the way that it is designed is that there's a timer in the upper right-hand corner letting you know how much time is left. It starts when you start that post encounter. And contrary to some other setups that we're able to do when we're in person, is that if you left the encounter a little early, sometimes you've got that total time. If there's 15 minutes for the encounter, 10 for the post encounter, you really had a total of 25. In this case, if you leave the encounter early, no extra time, 10 minutes from when you start the post encounter. So keep that in mind and you can watch the time. The design of it is that your typing freezes, and that can be a bit disconcerting. So watch the time, look through what you need to look through before the 10 minutes are up. And then another piece that I currently have set up, and Jules and I will be checking in with each other, is whether the honor code will be one time a day, just in the beginning, you do it once, or before each encounter. So if it is before each encounter, you'll see that on your to-do list in order. It'll be do that honor code, start the encounter, do the evaluation, and repeat that. And so I'll be checking with her about that. And those were all of my items. So thank you all for being here.
So the part that might not be completely obvious to you guys is the absolutely astronomical amount of work that Carol has done to learn this new system, to test it and retest it, to teach it to dozens of non-technically oriented standardized patients, to practice and rehearse. It's really been impressive. And I will say for myself, I participated in training earlier this week so I could understand what you guys were going to go through. And I was very intimidated by this. And I was like, oh my God, this is going to be a disaster. It's a whole new system. It's a mess. I mean, I went in my room, I talked to my patient, I came out, I wrote my note, I clicked submit, I went to my next encounter. Like, it was very smooth and very straightforward. And as people who know how SP exams flow, you guys really shouldn't have any difficulty with it, because Carol has taken all those variables out and made it appear very smooth and seamless. So we owe her an immense debt of gratitude for that.
You're welcome, my pleasure. And I do want to add a piece. There is a lot of setup ahead of time. Thank you for the hands. And what we're going to do is we're going to rely on you to tell us if you have a problem. We're going to assume everything's going splendidly. And so don't like sit back and say, oh my gosh, this thing isn't working, I don't know what to do. Is speak up, contact us. Otherwise, I am able to see green lights. I'm able to see that as you progress through, but I will not know if you have a problem until, like, if you're into something that's supposed to take 10 minutes, I won't know that it hasn't been done until it's all over. So much rather that you contact us, figure it out right in the beginning, but also have faith that you can do it. You click here, you click there. That's all there is.
Yeah. Yeah. And the nice thing, I mean, with the exam being formative this year, like, honestly, if something crazy happens and you get zapped out of an encounter, nothing bad happens. You lose the experience and we lose the data, both of which are regrettable, but nothing bad is going to happen to you. And again, knowing where things can potentially go wrong and how often they do is part of understanding the feasibility of this type of exam. So it's really helpful for us to just learn how to run them. All right, any questions from the audience at this juncture? Okay, my last part for those who are interested are my patented Jules Young success tips. So, you know, we kind of alluded to some of these things already in our discussion, but, you know, one thing that is a common source of loss of points for students is simply failing to have a standard system or approach to every single patient. So the more you can kind of get yourself in the mindset of, I always do the same thing the same way every time. I start by looking at the chief complaint and vital signs, then I do the HPI, then I do the past medical, past surgical, meds, allergies, family, social. Every time, same order. I always ask, even if it's not like, you know, the top thing on my mind, you're gonna ensure that you don't miss points because of silly omissions. And I see this a lot, actually. Like, it seems so obvious, but in the moment of an actual exam, especially when you're like trying to think on your feet and you're trying to figure out the right answer, and then the SP throws a curveball at you and they ask you some question or take you in some different direction, students can get sidetracked and not end up going through all those systematic components of the H&P. And that's a really, really common source of lost points on exams like this. And it's also a common source of missed data in real life. Because, you know, you would think that patients would be like falling over themselves to tell us the essential things that we need to know to take the best possible care of them. But unfortunately, they're not always doing that. So just make sure that you are systematic and orderly in your data gathering. 2, make sure you keep an eye on the time. So you have 15 minutes for the SP encounter. Again, that 5-minute warning at the end once you've gone through 10 minutes of your encounter is a great time to wrap up your data gathering piece and start thinking about formulating your differential and your plan and discussing that with the patient. If you are still asking questions at minute 14, that's going to hurt you in terms of at least your communication skills, because you won't have completed some of the functions of the interview, like providing information from the patient to the patient about what you think is wrong and what's going to happen next. And it's probably not going to engender a lot of confidence in the patient. So make sure you leave yourself time to have that wrap up discussion, and leave yourself some thinking time as well. You know, once you've gathered your information, you don't have to keep the conversation going every second. You know, this is a professional encounter. If you need a moment to go through your notes and just sort of, you know, think through, have I missed anything? What is my differential? Are there other pieces of data I need to gather to address that differential? It's fine to give yourself a moment to do that, but do that at minute 10, not at minute 14 and a half, okay? Some other places where students commonly struggle on this exam, we talked about communication skills, and one thing I will say is that I'm hoping that this being a formative exam makes the communication skills piece a little bit easier, because honestly, the students who I see have the most trouble with communication skills are those whose like wheels are turning so hard in their brains. They're trying so hard to figure out the right answer. They're trying so hard to make sure they asked all the right questions and they didn't miss anything, that they forget that this other person they're talking to is a human with thoughts and feelings and opinions. So I'm hoping that, you know, that won't be as difficult for you guys with this being a formative exam, because you won't feel like, oh my God, the world's going to end if I fail to ask about, you know, whatever, some particular thing. And you're going to be a little bit more focused on the humanistic aspects. But you are going to have that additional challenge of the online interface being a much harder way to connect with people. So just be mindful of that. Be mindful of whether you're making eye contact, whether you're, you know, appropriately monitoring your patient's voice tone and facial expressions. Be mindful of checking in with them frequently to make sure that it's a true exchange of information and a two-way street, and not just you sucking data out of the patient. All right. As far as the clinical reasoning note goes, that is often the hardest part of the exam for students, because you guys have all learned how to do pretty good H&Ps, but then taking that data and putting it into a note that adequately documents everything that's important, and that includes a differential diagnosis that is really supported with data. That's an area where I have seen students have a little bit of difficulty in the past. So let me just pull up, I have a couple of examples. Just give me half a second to find the one that I am looking for. Okay, so one thing, I'm gonna actually share this slide. My God, I have way too many windows open. It's totally confusing. So one thing that might be obvious to some of you, but is apparently not obvious to all of you, is that diagnostic workup and management plan are two different things. So I see surprisingly often students just putting the same thing in both boxes and not understanding that they're asking different questions. So just to be crystal clear about this, a diagnostic workup are things that would allow you to know what the patient's diagnosis is. So it would be tests, right? Additional exam maneuvers, radiology studies, laboratory studies, EKGs, biopsies, you know, all of those kinds of things that tell us what is wrong with this person. That's what goes in your diagnostic workup section. The management plan section, which again is not part of USMLE, is going to be focused on treatments. What would you do to make the symptoms that the patient's having better? What would you do to stabilize their underlying disease process? What procedures would you perform for this patient? Who would you consult for this patient, with the idea being that that person might want to undertake a treatment or procedure? So management is going to be all the things that are designed to either alleviate the patient's suffering or to actually modify their underlying disease process. Does that make sense to everybody? Yeah? Any questions so far? Again, I know it feels super obvious to say it, but I see over and over again that it's a problem for some students. The other thing that comes up a lot as a problem in the notes is the reasoning component. So when you list out your differential diagnosis, you are required to list supporting data from your H&P that that suggests that that diagnosis should be considered. It's really, really important that you are specific in what items you put. So, you know, for example, say you have a patient with chest pain and you list as your differential diagnosis myocardial infarction. You shouldn't just put in like, what is your supporting data? Chest pain. Like, great. So you understand that there's some generic association between chest pain and MI. That's not really that helpful to me. I would expect a layperson to know that as well. When you tell me that the patient's chest pain is supportive of the diagnosis of MI, I want to know that that pain is crushing. I want to know that it's located in the substernal area and radiates to the jaw or the arm. I want to know that it gets worse when they exert themselves, right? I want to know about aspects of the pain that make me think, not just in general, oh yeah, chest pain, MI. I want to think specifically, what is it about this person's pain that makes me think it's MI rather than some other different cause of chest pain? Similarly, if you're going to include, you know, risk factors in your reasoning, be specific about what they are. Tell me, I know that it's not just that this is an older person who's got lots of comorbidities, but I know it's their hypertension, their diabetes, their hyperlipidemia, their smoking. Those are the things that increase their risk of coronary vascular disease. So be specific in your reasoning, be thorough in listing your reasoning. Don't just dash off a word or two, because that's probably not going to be enough. Does that make sense to everybody? The last thing I want to say, just in my pro tips for success, and then I'm going to open it up for general questions. I am often surprised at seeing a pretty good differential diagnosis and then a plan that has nothing to do with the differential diagnosis that's been listed. So clearly your plan for the patient should stem from your differential diagnosis. You should do tests that will help you rule in or rule out the things on your differential. You should perform treatments that will help with the symptoms or underlying disease processes that are listed on your differential. If those things aren't matching up, if your plan doesn't correlate well with your differential, one of them is wrong. And you should take a moment to think about which one and adjust it accordingly. And this is an example that I literally took from a note from a student who did not pass this domain of the exam. So they gave me a differential diagnosis for a patient with chest pain of myocardial infarction, pulmonary embolism, and pneumonia. And the diagnostic tests that they wanted to obtain were an echocardiogram and a right upper quadrant ultrasound. And the treatments that they wanted to provide were an H2 blocker and a surgical consult. Now, the echo, you could maybe put together with, like, if they're thinking a massive PE, maybe they're being real sophisticated, thinking about right heart strain. Maybe they're looking for wall motion abnormality on the MI or for the MI, but they didn't ask for an EKG. They didn't ask for troponins. They didn't ask for a D-dimer or a chest CT or the more standard diagnostics associated with those. So I had to like really stretch to think why they would want an echo. They list pneumonia as their third differential with no test that would help me know about whether or not pneumonia was there, yet they want a ultrasound to look for gallbladder disease. Now, clearly that can present with chest pain, but there's nothing about biliary colic in this differential. So from my perspective, this is coming out of left field, right? Similarly, GERD can cause chest pain, and we treat lots of people with chest pain with H2 blockers, but GERD isn't on the list up here, so I don't really know where that's coming from. And I really, despite my best efforts to get inside this person's head, I couldn't fathom what we were looking for with a surgery consult. So bottom line is, you know, you give me a differential like this, you probably want an EKG. You want troponins, you want a chest x-ray, you want either a D-dimer or a CTA of the chest. You probably want to give the patient some aspirin if you think they might be having an MI, some nitro or morphine for angina. You're probably going to want to think about other disease modifying treatments based on the results of your workup. So you want the things that you put in your plan to match up with the differential that you provide. And if you find that there's something you really, really want in your differential that you're not backing up with a test or treatment, you should probably rethink whether that thing belongs in your differential or vice versa. Does that make sense to everybody? Fantastic. Okay, what questions do you guys have? None? I've covered everything perfectly. I've bored you so much that you're all unconscious. None of you are really even still at the computer. All right. Well, if you guys don't have any questions, we can be done. I greatly appreciate you guys coming to this and taking the time out of your day to learn a little bit more about the exam. I hope you found it helpful. I certainly hope it reduced any anxiety or concern you might have about the exam. If you have any questions that you think of later, you guys know I'm pretty accessible. You can reach out, email me anytime. I'm happy to talk to you. And I will look forward to seeing all of you guys. I'll be dropping in and out of some of the rooms on exam day to see how things are going. So you might see me as a lurking stalker in one of your rooms, but otherwise I will set you all free. And I'm going to stay on to re-record the beginning of the presentation that I neglected to turn on the record button for. So thanks again to whoever reminded me about that. I hope you guys have a great night.
I'm going to stop the recording now, Jules.
Perfect.